If you had $1 million to spend, if you're a minister of health, what are the best buys? What was the economic decision that you should make that would give you the best bang for your buck? And when you look at the global burden of disease, look at life expectancy in the world, outside of sub-Saharan Africa, in India and China and Latin America and other parts of Asia, life expectancy has really gotten longer. So in a place like China, life expectancy in 1960 was about 39 years. By the year 2000, it was up to 74 years. So it's the greatest prolongation of life in the history of humanity. And it means that global health for China is no longer just the childhood illnesses and family planning. It's really the chronic disease agenda. And it's that way for all the world except sub-Saharan Africa, where the infectious diseases, AIDS, are the key determinants. Now, chronic diseases are important there too, but the other infectious diseases, HIV, diarrheal disease, childhood illness, are all key. And that was very interesting for me, because it meant that half of the best buys were in the chronic disease arena. For many parts of the world, the countries, when they think about global health, had to think about diseases of cancer, of cardiovascular disease, and stroke. It also gave me a hunting license, because my second title at NIH is the Associate Director for Global Health. And in that capacity, I have 26 other institutes and centers to work with, one that works on infectious diseases, but 25 others that mainly deal with other issues, or primarily deal with other issues. And so it began a conversation that I've been having with each of the other institutes and centers to think about the global burden of disease and their participation. For instance, the number 2 cause of DALYs was mental illness. And yet in the National Institute for Mental Health, there wasn't a robust program for global health, despite the fact that they owned the number 2 cause of disability-adjusted life years. So how do you deal with this when someone delivers to your door an international document that says that you're the second largest owner of disability-adjusted years? What program do you begin to think about? That you own those problems. How are you going to address them? We then called a meeting of the different institute and center directors, and we asked many of the institute and center directors to get up and tell us about global health. This was with Dr. Zerhouni, the last director. And once you challenge people to stand on the stage and say what they're doing, they rise to the occasion. So Betsy Nabel was the head of the Heart and Lung Institute, and she spoke. And she said, well, really, global health is cardiovascular disease, because the number 1 cause of death in the world today and in the developing world, heart disease. So cardiovascular disease is ours, and we're in global health in a big way. And then the head of the NCI stepped forward, and he said, in fact, cancer is big in the developing world. 80% of the cancers in the world today, in the developing world, the low and middle income countries. So cancer really needs to be in global health. And sort of everybody came around to different realizations. The National Institute of Environmental Health Sciences said the same. If you want to study arsenic in drinking water, where do you go? You go to Bangladesh, and you go to parts of India where arsenic is a contaminant. So we're into global health. Everyone went around, and I think there's been a growing interest in the global health agenda. It also means that for our fellowship and scholars and fellows programs, it means that as I go around and expand the programs that we have for training, kooky things like a cardiologist interested in global health, I don't know if I could find one, but you're going to hear about this today. Yeah. How about kooky people that think about cervical cancer as a global health problem? Is that a global health problem? Got another kooky person down there who's going to talk about this. So in fact, as you begin to think about where we are and where we're going, global health will have a much broader agenda. And next month, we're going to China with the head of the National Institute of Neurologic Disease and Stroke and the acting head of Heart and Lung Institute and the director of NIH. What's the question in China that we want to ask? What's the number 1 cause of death in China today? Stroke and hypertension. And the deputy head of the Neurologic Institute came down to my office 2 years ago and said, you know, he said, I've never worked internationally, but in China, stroke is the #1 cause of death. The lesions are intracerebral and not large vessel, and they're hemorrhagic. It's a different kind of stroke than we have in the U.S. What can we learn about it? What can we do to prevent it? We have lots of Asian Americans in the U.S. Do they have the same risk? That resolving the stroke issue in China can inform us at home of what to do. Resolving, if it's only salt-related, can help us think about what we can do at home. So there's a lot that we can learn by thinking with the Chinese about the issue of stroke. So my first message is that global health and research in the 21st century still has the issues of infectious disease, of AIDS, of all the other childhood illnesses, but that the chronic disease agenda is something we all have to think about. And whether you're in ophthalmology and worried about trachoma or dermatology or bioengineering, these are all suitable subjects for the research agenda for the 21st century. The second point I want to make is that when I first got to NIH 4 years ago and took this job, I was asked to go to Rice to speak to a bunch of bioengineers. Head of the National Institute of Bioimaging, Bioengineering, put it to me, he said, you got to talk to these kids about global health, undergraduates. I said, useless. I said, I don't know anything about engineering. I don't know anything about bioengineering. I can't imagine why you want me to do this. He said, just go do it. So I went down to Rice, and Rebecca Richards-Corton was my hostess, and she's the professor of the program for undergraduates. And it was the most incredible and eye-opening experience for me, because they had about 40 students who were in undergraduates and summer programs. Each one had a project to go out into the developing world and address an engineering question. For instance, the delivery of antiretrovirals in an African community requires refrigeration. And how in a community that has no refrigeration do you supply drugs to a parent for a month's duration that has to be refrigerated in a community that has no electricity? And how do you do that for $50? How do you make a device that works? And this is an engineer's type of a task. I wouldn't have a clue of how to do that, yet this is absolutely critical to that mission of delivering antiretrovirals. And there were a bunch of kids who had gone out, you know, they're Texans, so you have to start with a beer container, a beer cooler as your refrigeration device, because it's under $10, and attach it to different, an old car battery, which can fuel a unit to refrigerate a canister of water that can be recycled through the beer container and work for a month and figure out the characteristics. It was fabulous. Every kid who had gone for a summer program had been engaged in a global health mission, an engineering mission, and I came back realizing that bioengineering was as integral to the solutions in global health as epidemiology and cardiology and infectious diseases. So I think with that, I've come to the realization, and in our framework programs, we have the realization that global health in the 21st century is not just going to be medicine, public health, and nursing. It's going to be bioengineering. It's going to be bioinformatics and broadband delivery and IT and communications. It's going to be law and biomedical ethics and taxes and economic policies. It's going to be anthropology. It's going to be much broader than what we think of as pure biomedical science. And if we don't recognize that, we're not going to be pushing the agenda. Behavioral sciences, economics, and like. So multidisciplinarity in that framework program that I spoke about this morning is specifically designed not to give the grant to a school of public health or a medical school or a department of global health, but to give it to at the university level and to make sure that you have at least three colleges, centers in the university involved in the global health agenda. So they talk together, they interact, and think about global health in a different context. So that's the second point, multidisciplinarity. The third is dealing with partnerships. You know, I had the dizzying slide of partnerships, and it's really clear that when you have the smallest center at NIH, that the partnerships are key. And part of what we've been doing at Fogarty is to see how we can partner with every level of partnership available. So I mentioned the other institutes and centers, and we've been very successful in getting other institutes and centers to support some of the training programs that we have, where we're training cardiologists to continue a research career in global cardiology, or cancer people to think about future careers in global cancer. And we'd like to see that expand. My ability to do that and to partner has to do with your ability to send me creative ideas and wonderful people who can push the envelope and let us engage with the dentists that we've had and the dermatologists that we'd like to see and the bioengineers and the kooky people with information technology who know how to use mobile phones or broadband. Geeks. Okay, geeks for global health. You've got it, and you can all think of ways, ways and people that can do this. I think the idea of logistics and cold chain is as key and fundamental to immunization programs. We need ways to do this. So partnerships is critical. I was a Fulbright scholar many years ago. And I've seen in the Fulbright program, they've gone away from biomedical sciences and sciences in general to the social sciences. And yet they have several thousand trainees a year, and it's a wonderful program. So we've just started our partnership with the Fulbright program. I'd love to see that go from 5 fellows to maybe 500 or at least 50 over the next couple of years as an expansion area. And finally, and I think we're here today because we have this Fogarty Fellowship Program. It was started by Aaron Primack. Pierce Garden is in front of me, who's been our ambassador. Stan Vermund has moved this forward. But the real value of this are the fellows and how we affect their futures and their careers. I know for myself that a few years ago, CDC sent me to Bangladesh for 2 years to work on diarrheal diseases. You might say that was probably the worst useless expense that CDC ever paid, to send someone with marginal ability in diarrheal disease and no international experience in doing field research to address this kind of a problem. And yet, 30 years later, I'm still working on diarrheal disease research, and the return on those 2 years of investment were 28 years of a career in diarrheal disease control. I first met Bill Popp when he was a diarrheal disease guy back in the late 70s, early 80s. Mike Merson, Peter Pio, all started with that early childhood experience in developing countries, and you can see that each of them has had a robust career in the global health area. So I say that as an introduction to the 3 wonderful speakers we have today who are at the other side of their career trajectory. They've all had their early childhood experience, at least the first year or 2 of it. They're all in a position to recollect how that experience has helped them and how they can move this forward. And I think the ultimate desire for us at Fogarty is to see that these training experiences really fuels a long-term investment in biomedical research, in health research, and health research in global health that will make them leaders in 5, 10, 15 years. Very hard to assess their contribution today. They've only been back from their fellowship for a year, 2, 3, no more than 6. And in fact, the leadership in academic field only begins early, but really resonates as you get older. So it's very hard to assess in the short term, what are these investments going to do in the long term? But I think if we were to assess that more critically, the return on investment is probably the best investment that we make. Investments in people, and investments in people who will be leaders in research and in the career areas. So with that introduction, I'm delighted that you 3 are here. You are really the stars today, and I'm really just the guy who warms up the audience to hear what you've done and where you're going with it. So my congratulations to you and to the other about 200 fellows who will be coming to our anniversary symposium this Friday, Saturday, and Sunday. And my hope with all of you characters is that we can get the other institutes and centers at NIH to realize the value of their investments in the future research activities in their fields, and will buy on to global health research as an integral part and a new frontier of their own research agendas. So thank you very much.